Hello, everyone. Are you ready for our club webinar number 27? Already on 27. We are going to talk about critical care today. We had a topic request come in. Let me just get my cursor moved over in the right place. And they wanted to know more information about critical care. So I took their long question and kind of divided it up into the topics that they asked for to make it a little more user-friendly to share with you guys. So this is what they wanted to know. They really wanted to know, what constitutes critical care? What do you need to know when you're coding for critical care? Because it seems pretty intense, but it actually is quite simple. You don't have many codes at all that you're dealing with. And the criteria, once you get it in your head, it's easy, but it's not something that is commonly coded unless you work at a facility that has an ICU or even ER departments. Not everything that comes through is critical care. You have a lot of, babies with fevers and fractures and stuff like that. That is not critical care. Even if you have a motor vehicle accident, it may not even be critical care. So again, what do we need to know when we are going to code it? Mistakes that are commonly made with critical care and some examples. And we have lots and lots of examples. I've got 3 answer sheets like we do with our Q&A webinar. And of course, you'll be able to get access to those if you're in the CCO Club that have the answers there. So we're just looking at critical care codes. We're not really looking at diagnosis codes, but the E&M portion of critical care. The first thing that we need to go over is the basic terminology. What constitutes critical care? Now, I went out and found more than one definition to explain this, and we're going to reiterate it again and again. So you may see something similar to this repeated, but the reason I did that is so that we can get that into our brains. What it means for critical care for CPT, as they defined it, is that you're managing an unstable or critically ill. Now, this is stating stroke patient because that's where I got this example from, okay? So it doesn't have to be a stroke patient, but like a stroke patient is what it really should say. They are going to be admitted, and the criteria is going to be keywords like they are unstable, and they use the term critically ill. You'll see that in the documentation. They are telling in this guide for critical care for stroke patients that you should use that verbiage when you document. The provider needs to say the patient is unstable and that they are critically ill. Okay. Also, they made a point to say when you're doing the codes for critical care, it's not like other E&Ms where you have bullets, right? And you just check off that, okay, we did the exam. How many body systems did we go over? 1, 2, 3, they don't do that. It is based on time and the fact that the patient is critically ill. So we need to know how to determine time, and they do it in units, and we need to know what constitutes someone being critically ill. Is there gray area in critical definition of being critically ill? So I went and looked at the definition that Medicare put out, and they actually state that if you are in critical care, again, critical ill and unstable, those are those keywords that you saw that they were telling you with the stroke patient, it's going to require that the provider is going to need to give complete attention to the patient. So when the provider comes in And let's use an example of a patient that's in ICU. They're not going to be looking at more than one patient. No, it's one patient and that's it. Their complete focus is on that patient, whether it's an emergency or not. Right. So if you're in the ICU, you're not dealing with an emergency. They are critically ill, but it's they could still be in a stable condition but critically ill, not an emergency. So if you classify it as an emergency because it comes in, right, and everything's acute that you're working on, whereas when you're in an ICU, an intensive care unit, they've stabilized you to the point that they can monitor you, right? But that doesn't mean you're out of the woods. When you're in ICU, it usually means the criteria for being in intensive care is that you're in a critical state at that point. We also know that if the patient is unstable or critically ill, then it's a really high decision making. And so decision making for E&M for critical care isn't the same as it is for an established patient or a new patient in CPT for outpatient services, and it's not the same as an inpatient status. Well, of course, you're not going to be doing E&M there anyway. It is kind of the only area that has that E&M component for inpatient is critical care. Another thing that besides the medical decision making that we need to work on one of the organ systems failing is usually what we're looking at. So they have to be able to support the ones that are listed. They say circulatory, respiratory, central nervous system, metabolic, or other vital systems so that they can prevent or treat organ failure. Right now, it doesn't have to be it could be one organ failure or it could be multiple organ failures. And most of the time when you're looking at ICU, you've got multiple organ failures, not always, but in the scenarios that I've seen, that ultimately that's what we see. All right, so that gives you the kind of a look closer in depth as to what critical is and the patient being unstable. Where are you going to find these patients? Well, for a facility, the coronary care unit, and there are different verbiages that you see in different facilities. You have coronary care unit could have the cath lab in it, and it could have step down, which would be, like cardiac or step down. So anything that was done to the patient, any procedures, they aren't in, they're in the coronary care unit, but they're in step down section. So they've had their procedure and they're just being observed, right? But they could have critical coronary care units. And this is where, like you would have people that were having valve replacements and heart transplants and heart procedures. You have the ICU, which is the intensive care unit. You have, and everybody's usually familiar with that. Then you have the PICU, which is pediatric intensive care unit, the NICU, which is the neonatal intensive care unit, and that is all divided up in age from pediatric to NIC, the neonatal. There's also a respiratory care unit in some larger facilities that's what they're dealing with. They only work, they specialize with respiratory failure or getting respiratory support. And then of course you have your ER or ED, emergency department or emergency room, depending on what verbiage your facility is going to be using. This is where you're going to see the critical care coding being done. This was a fabulous article I found, and it came from Find a Code. It was by Nicole, and I do have Find a Code up, and I'm going to show you how to reference it because it specifically stated that if we wanted to share that, we had to show the entire article. But the components of the article that I wanted to show was only a third of it. So we did give a link, and it talks about more than just critical care, but the components that they said about critical care were excellent, and I wanted you to see it. Now, I pulled from different sources the descriptions and the content to show you how to also do your own research. So not only can you do this for critical care, I want to show you how easy it is to be able to do the research when you want to look for something else, right? So again, critical care would be one component, but let's say you wanted to go and do research on a specific type of anesthesia, right, or coding out anesthesia. So again, I'm going to show you how you can take what I'm going to show you and move it for other subjects. Well, the World Health Organization ultimately is where Nicole got this, and it was published on Find a Code, their website, in one of their articles. And she was talking about how to support the billing levels for different types of E&M coding, and this was the part on critical care. This is everything that has to be in the encounter or the chart. If it's critical care, you're dealing with the chart, really. And so let's break those down. Of course, like all documentation, you're going to need to know who the patient is. And you will see on every documentation the patient's name, date of birth, and the date of service. Right. Now, if you're in a facility, you're also probably given a number, an identification number. And nowadays, unlike what we did when I was working and doing facility work, and actually doing work with the clinicians and things, you would go in and you would look at their name band, right? Or you'd go in and you'd ask them their name, and but that was it. And then it got to where, no, you had to verbalize their name and date of birth, kind of like the protocol changed, you know. And so every time the nurse would come in, even if she saw you 3 times in her shift, you know, to come in and check on you, especially if she's administering any medication, she would say, you know, what's your name? And you would say, you know, my name is Susie Awesome, and they'd say, and what's your birthday? You know, and they kind of make a joke of it, and you would say, my birth date is 7/7/68. That's my birthday, by the way, and I'm not Susie Awesome, but now you know my birthday. Don't forget it. So again, you would repeat that every single time somebody came in. So if the respiratory therapist came in, they'd ask you the same thing. Now, not only do they ask you, but that often that armband has a barcode, a scannable code. So they'll come in and they'll say, you know, what's your name? What's your birth date? And they'll kind of, you know, yes, you got to tell me, because well, a patient that I was with the other day said, well, it was the same 5 minutes ago as it is now, you know, and then they would scan your wrist, right? And it would go beep, beep, and they would know that they were giving, then they would scan the medicine or whatever they were going to do to you. So again, every one of the document pages are going to have this information on it. You have to have a progress note, and it has to be signed before you can bill it. It has to have the total time that the provider was with the patient, and we're going to talk about that in depth. And it needs to have a documentation of what the medical decision making was, and that the patient was critically ill, and describe how they were critically ill. You can't just say the patient was critically ill and let that be, and let that stand by itself. You've got to give the documentation to substantiate that. The last bullet point is that you must be aware that the billing provider, the one who is submitting the code for billing, that is responsible for everything in that record, right? So they're the ones that are responsible for every service that's being rendered to that patient because they're in charge, right? Now, I'll go and show you here in a little bit. Well, in fact, let me just see. I'm going to show you, bring it over, that particular code and find a code. I'm going to get rid of the dashboard. I want you to, if you guys are using an encoder, almost every encoder will have this, right? So this is one of the basic codes that will, one of the codes and the add-on code that goes with it for critical care. These are all of the options that you can have. And see all the articles that I was able to reference? And they got them in date. They also have Coding Clinic. They have Decision Health, which 309 articles. Right? There's coding tips, everything that you need to know. Now, not everybody that has the encoder will have access to everything here. It's based on what you pay for. Right? So I've got access to more content, 45 articles via coding assist or CPT assistant articles, Coding Clinic. There's 11 articles, and when you look at those, they're based on dates. So I did pull out this 2011 and grab that content and put it on the slide deck for you. And I also pulled a little bit of verbiage that was in the 2008 because I thought it was applicable. So you can see those. Now, when you look at these, let me see if I can find, this is the one, I'm trying to find her article. That was really, really good. It was CPT Assistant, I believe. No, I'll use the link at the bottom. Okay, so again, don't forget, and we'll come back and we'll look at that full. And I really like how Find a Code is color-coded, but any encoder will work for you. But again, I'm partial to them. Okay. So the two codes, the two main codes that you're going to be using for critical care is going to be 99291 and 99292, which is the add-on code. Everything is based on time with critical care and the verbiage on what's wrong with the patient. So let's just read the description of 99291. You have critical care. It's the E&M of the critically ill or critically injured patient. Really important here. First 30 to 74 minutes, not 75, 74 minutes. If you go over 74 minutes, then you're going to use the add-on code. You can't use this code by itself, 99292, which has the exact same description as 99291, except it's each additional 30 minutes. Now, note what we have in our parentheses. You're going to list separately in addition to the code for the primary service. So you're going to list, let's say that you had a patient that was seen by the provider, critical care evaluation and management, and they saw the patient for 75 minutes. Then it would be 99291, and then you would code 99291 for each additional 30 minutes. Even though you didn't use a full 30 minutes. It's in that 30-minute window because 99291 goes up to 74 minutes, not 75, right? Now we're going to have lots of examples of this. Those are the two codes, and when you open up your CPT manual and you look at these codes, it will be critical codes, critical care. You're going to write above those. Of course, if you're doing the BAT technique, you've probably already done this, but if you haven't done your BAT technique, there will be notes here. You are going to highlight that it's the first 30 to 74 minutes, right, for 99291. And then for 99292, you're going to highlight each additional 30 minutes, right? And you're going to bubble those two codes by themselves. I want to go over basic facts. Now, remember I told you that that first description came from a stroke document? Fabulous. This is the link to that. It was amazing. And they gave the information in such a way, even though it was for clinicians, it was perfect. So I just broke them down into facts, and we're going to go through them separately. When you have the first thing you need to know about the critical care patient is that they have to have the verbiage that it's critical care and it's based on time. Then you need to keep in mind that it does not include consults. You will not use those two codes that we just talked about if the patient is having a consult. So let's say you have a critical care patient and the provider in charge says, hey, we need to get a cardiologist to come in and consult. You don't use that. They're going to use a consult code, right? But you can have more than one provider using those critical care codes, right? This is, we're going to give examples of that. Now, this is where it gets a little confusing. So the example that they gave, and keep in mind, this is based on coding for a stroke patient, which would be critically ill. You can have more than one neurologist working together, right? Even if you had two neurologists and they do two separate shifts, so you have like the morning 12 hours and then you have the next 12 hours, then you've got them working together. What would happen if they meet this criteria? You have them, they're in the same group, they share the same Medicare provider ID number. Now, if they don't share that same ID number, then they're separate. They're going to bill separate. But if they do share that same ID number for Medicare, then you're going to add the hours together, the 12 and the 12, right? So the second shift doctor is going to add their total bill to combine with the first shift. So you have 24 hours instead of 12 and 12. Now that gets confusing. So you, as the coder, how do you know? Well, you have access to all of that documentation. You have access to the providers, who they are, who they work for, right? And you actually have access to their Medicare numbers, you know, to know, because the content that you're filling in, when they log in, it will have that in there, right? So don't think you'd be thrown out there. What if you have more than one specialty? Okay, that changes everything. And it would be very common for you to have a neurologist come in and treat the stroke patient, but the neurologist is not the ICU physician that is taking care of the patient, right? They're a specialist because it's a stroke. Now, you think to yourself, I can see the wheels turning, and you're telling yourself, but wait, wouldn't the neurologist be primary because it's a stroke patient? No, not necessarily. And they're not giving in a consult, right? They are actually managing the components of care for that patient for the stroke, everything that involves the brain, right? The nerves as well. So you have a neurologist, and then you have the ICU physician. And so say the ICU physician is taking care of that patient, that the component, the part that's been the patient that's been intubated because they can't breathe on their own because of the stroke, is the example that they gave. So they are both working as a group in a combined effort to manage the care for that patient. But they are separate specialties, the ICU specialist and the neurologist specialist. They're working as a team. So each one of them is going to they're not going to combine those critical care codes. They're going to do them separate. So if the neurologist comes in and spends 50 minutes with the patient on day 1, and the ICU physician comes in and manages, say, the ventilation, hooking the patient up to the ventilator and, writing the plan of care, the whole 9 yards of doing the pre-op, post-op, and everything that needs to be done to have that person intubated. Let's say they do a tracheostomy and they spend 78 minutes, right? The first provider is going to use that first code, the critical care code, once, because it's 30 to 74 minutes. But the second provider, the ICU doctor, is going to be able to code both codes, the initial code plus the add-on code, because they were managing a longer time of care and was treating that patient for a longer amount of time. And I can't remember what I said now, but what I say, like 78 minutes or whatever, right? Because it's over 74 minutes plus each additional 30 minutes afterwards. Okay. Great article. I would like for you to make a note of this particular link and use that to go out, and you can put in the journals.lww.com and then probably just go to their search and put in stroke coding guide for critical care, or you could probably just put in critical care and it would come up for you. If it doesn't come up off what you're seeing, but we have the link at the end. All right, the next thing is the location. You have to be very familiar with the location. Now, we already talked about where are the common places that you're going to see a critical care patient, and most people automatically think of the ER or the ED, whichever I'm old school. We used to call it the ER. Now they call it the emergency department. So I have a hard time saying ED. So even though it's written ED, I'll probably say ER. Just be patient and forgive me for that lapse. This is really, really interesting. So if the ER doc is taking over, is doing the care for the critically ill patient. So they come in. So let's say we have a patient that is in a motor vehicle accident, and they know there's head trauma, there's chest trauma, and they need to get x-rays, and that doctor is following the patient, right? It doesn't matter where they're at. They can leave the ER and follow that patient to radiology and look at the scans, right? And that still is, the clock is still ticking, right? You don't have to just say, okay, we've got X amount of minutes in the ER, and then we have, 30 minutes in radiology and because they'll move them to radiology, but they don't really usually move them anyplace else, right? And if they have to, they'll just bring radiology over to you and take pictures. But like if they have to do a CT scan or MRI or something like that, then of course they're going to move the patient. And sometimes they're being intubated. Sometimes they're being bagged during that time. They could be doing several things while that patient is critical, and they've got to get those scans in. So it stays the same. Those hours and minutes stay together because it's the one provider and they're staying with the patient, that care. They're not taking care of other patients either, right? That's their one primary patient. Even if a patient's in ICU and they say, hey, we need to get a CAT scan. So they have to wheel the patient out and take him to radiology and do that CAT scan, but the provider is following their care even when they're doing the CAT scan. So they have a great example where you have 45 minutes that the patient is in the ER and they're doing their evaluation. And then there's 45 minutes in radiology, and the provider then goes to the ER and gets, or excuse me, the ICU, and gets them all set up in ICU, and he manages the patient being admitted into ICU. So total, you have 45 minutes in the ER, you have 45 minutes in radiology, and you have an hour in the ICU, then you're going to get to bill a total of 2 hours and 30 minutes for critical care for that one provider, because they followed the care all over the place. Now, these are the type of questions that you're going to see on the exams when you're dealing with critical care, right? You need to know that it's okay for the provider to be taking care of the patient in the ER and in radiology, okay? You get to add them together. Location. There are some examples here, and Whitney has asked some questions, and I think, Whitney, I'm going to let me wait to answer those till the end, okay? Go ahead and keep typing. If anybody has a question and you're on live with us, feel free, go ahead and type those questions. I'm going to keep my eye over here and see them coming in, but I think that I'm going to address one of your questions in another slide. But one of them I see, I don't think I did. So that'll be something that we can add. We got a question time at the end. The other thing that we need to be aware of is time. And if your patient is sent to the ICU, then it isn't going to count time away when you're spent off the floor, right? So you can't count that. So if the patient's sent to the ICU and you go to take care of another patient on the floor, can't count that, right? Because you're not, one, you're not in the ICU with the patient, and two, you're not exclusively dealing with that one patient, right? And you also cannot count time that you go, say, to your office. And they use the example of making a phone call. So say you go to your office and you want to confer or check and see if you can get a specialist to come in. That doesn't count, right? Because you've walked away from the patient. You're not on the same floor in the unit with the patient. So you say, oh, wait, but they can go to radiology. Yeah, they can go to radiology, but you're following them to radiology. You're right behind them. You're behind that glass seeing the scans when they come up, and you're spending time. It's not the same thing. It's different. So if you go out on the floor, even if you're talking about the patient and it pertains to the patient, doesn't count. If you go to your office, even if you're doing something that pertains to the patient, it's different. Okay. It only counts when you are in that unit with the patient, where the patient is. Now, can you be in the ICU and the patient's over here and you're clear on the other side of the room because that's where your desk is set up and that's where you document? Yes, because you're still in the department. Okay. Does that make sense? Right. Okay. So moving forward, what about family time? If you need to talk to the family because the patient cannot speak for themselves because maybe they have been intubated, maybe they're not conscious, they're not alert and orientated, then the time that you spend talking with the family counts towards your time, okay? But only if it's documented that the patient is not able to verbalize for themselves. You know, they aren't able to speak for themselves. If that's not documented, then that family time is not counted. If the patient is able to speak for themselves, any of that talking to for critical care doesn't count. All right? Very important. What about if you have a resident that comes in to see the patient? There's so many teaching hospitals, and I know a lot of you out there also code for teaching hospitals. With critical care, resident time is not counted because they're not a billing entity. They are not the attending. So only the attending can bill for the time spent with the patient in critical care. So again, if you see something about a resident put in there, automatically tell yourself in critical care, they can't bill, you can't use that code. Definitely need a sippy. Okay, keeping my eye over there. Not seeing any questions. Moving on. When you are doing E&M coding and critical care coding or billing, so you're doing E&M code and critical care billing, you can bill for both if both services were provided. So critical care, you only have the 2 codes for your adults. We're going to talk about children in a little bit because those 2 codes are not always applicable for children. So heads up on that. So you can do the E&M code and you can also do critical care billing. But you have to make sure that there is documentation for both services. You have to have specific documentation time for the E&M code, and then you have to have specific documentation for the critical care. What constitutes for critical care? We know it's time and the verbiage describing it. So both, they are different. However, you can use the time that is counted for either the E&M or for critical care, but you can't put them together and add them together, right? So if you go in and you spend 20 minutes on E&M, but you spend 50, let's say 55 minutes on critical care, you can't add them together to get 75 minutes so that you can use both critical care codes, the original and the add-on code, because it would be 75 minutes over 70, 30 to 74. It's either for the E&M or for critical care service, but not for both. It's one or the other, right? Now, another thing that is kind of reiterating what we said in the beginning is, how are we describing a critical care patient? They could be critically ill or they could be critically injured. So when we talk about a patient that it has a stroke and they have to be intubated, that's critically ill. They have one or more vital organ system that is in failure, right? Or they wouldn't have been intubated. Immediate or imminent or life-threatening deterioration is what you're looking for, and that has to be in the description. And we've got some examples of how the provider verbalized that, and it's excellent. And I think they're really good at probably documenting this. I think they've probably been trained well for critical care, but you need to know this so that if you're in a position where you need to say, hey, this isn't, yeah, you said this patient was critical, but you didn't explain how they were critical and what you did for them that shows that they were critical. You just stated they were critical. I need more, to be able to use that critical care code. So if you have a patient that's had a stroke and they're in respiratory failure and they've been intubated, then you've got one or more organ system. Well, you've got neurological and respiratory, 2 organ systems. They've got them in respiratory failure, and these are life-threatening. So there you go. You, again, high complexity of decision making at all times, right? This was a great graphic that came also with this journals.lww.com. And I went ahead and put this on the answer sheet so that we can look at this. The reason I like this, and I could have reproduced it, but hey, they did such a great job, you know, so I just copied it and gave them attribution. Again, I really want you to go out and read this full article because it's that good. So we know that if we have a patient that is seen for critical care 30 to 74 minutes, that would be a half an hour to 1 hour and 14 minutes, then we're going to use 99291, right? Anything over 74 minutes, so it starts at 75, then we're going to use our 99291, and up to 104 minutes, it would be the additional 99292. But if we go to 105 minutes, right, and that would give us the 1 hour, 45 minutes to 2 hours and 14 minutes, you're going to write it as 99291 and 99292 times 2, or you can write 99292 twice. You know, it's however your biller or payment system wants you to do it. And it's probably times 2. Because look, when you get down to spending 194 minutes, which would be 3 hours and 14 minutes, then you've got your original code, 99291, which I like to call a parent code, and the little add-on code, 99292 times 4. Now, what do you do if we have more than 194 minutes? Well, you just keep adding it up. It's the 99291 with 99292 times 5. Okay, you just keep going. And can it happen? Yes. I've not seen it happen, but it could. I haven't seen all the documentation out there, have I? So this is a great graphic. You can create your own little template. And even maybe if you wanted to, you could write it in your manual if you knew that you're going to be working with critical care, or if this is confusing to you, right? Just have it. Now, if you're going to use it for testing purposes, you can't have it on something else external, but you could definitely write it in your manual. Find a place to write that. You're probably not going to get but maybe one critical care question on the CPC exam. The COC, I would say maybe one. But if you're doing the CIC, you're likely to see more, right? And then if you're doing any of the specialty exams, you could definitely see this. So now let's look at our case studies. So I'm going to go ahead and pull those over. Thanks for the questions coming in. And let me open up, let me grab A first. Now, if you are in our club, you'll have access to this. This is a great example from that particular site. We have some more examples, but what I did was I wanted to grab this because it, again, was for clinicians and providers to see how to code, right? That's why it was. And when you go back and look at it, you see actual verbiage. So let's look at this from an abstracting standpoint, right? We're only dealing with 2 codes. We already know. So it's going to give us practice counting time. But as we do that, because it's such a great example of a stroke patient, let's see the type of verbiage that should leap off the page to tell us this is a critical patient. We start out, it's an ER patient. So it says you're called to the ER. It's a 68-year-old man with onset of aphasia and right hemiplegia 2 hours ago. So again, stroke, right? This is a stroke case. That's what you're thinking of. So they tell you, you arrive at 6 o'clock, okay? Now, keywords, globally aphasic, no movement of the right extremities. Now, can you have a patient that has no movement of the right extremities and not be critically ill from a stroke? Yes, maybe. But globally aphasic with no movement on the right side, when you have that, that means that your airway is compromised. You can't swallow properly, so you're a choking hazard, just swallowing your own saliva. You would have major drooping in the face, right? And a person that has this is going to have cognitive disabilities. They're going to be able to understand you, most likely, or they could, but they are not going to be able to verbalize. Everything will be confusing to them because they will feel like their brain is working and they will want to be able to verbalize and tell you things, and they think that they're telling you. You can say, Mr. Jones, what happened today? And they could be they will try to verbalize and think that they are telling a whole story, and at the whole time it's coming, anyway, you have to see it. But if you understand how strokes work, and if you don't, you need to go and study more about the signs and symptoms and how strokes work. So that right there should be a red flag that this is probably a critically ill patient, globally aphasic, no movement of the right extremities. Okay. Now, the NIHSS score is an 18. Don't worry about that. Okay. A CT brain scan was done. Okay. So that doesn't give us anything to say that they're critical, because they do CT scans on people that are not critical. All those labs are normal, right? The wife is in the room. Okay. Now, if he is globally aphasic and has no movement on the right side, he is probably going to be nonverbal. He's going to be able to verbalize, but nobody's going to be able to understand what he's saying. So it's very important that you know now that the facts that we looked at on the guidelines, if the patient can't verbalize and you state that they can't verbalize, then the time spent talking to the family is counted, right? So now we know wife's in the room, and you find that he has a history of, so she's getting the history from the wife. We got hypertension, AFib, and he's on medicine, which includes a blood thinner. So that, is, again, not telling us that he's critical, but we're painting the picture of a stroke patient. No prior history of a stroke. And again, this is all stuff that isn't really pertinent to being critical. The blood pressure, again, is high, but fine. And it doesn't tell us that he's critical. So you do a TPA checklist. That means it's a checklist for stroke patients. And he is a candidate for IV TPA. Now, IV TPA is a new type. Well, it's not really that new anymore. But if you meet the criteria of the type of stroke that you have, they can inject you with this TPA, and it can bring you out of a stroke. Okay. So again, it is something that has to be monitored. So everything's explained. Again, more time. She consents. Okay. You mix the information for the bolus. It's given, and you administer the bolus. So you give the medication, and they start the IV. You write admission orders, dictate a note, and leave the ED at 7:10 p.m. Okay. You saw no other patients. You were only there to see this one patient in the ER, and you got there at 6. The whole time that you were with that patient from 6 to 7:10 is the hour and 10 minutes. And all of everything here indicates the patient's critical, right? Because they had to, if you had to have TPA, you're critical. So what do we know? You're going to document that you personally attended a critically ill patient, and we've established that they're critically ill, for 1 hour and 20 minutes, including, this is where you're backing up what you did, a stroke evaluation. You determine the appropriateness of administering TPA because, again, it has to be a specific type of stroke for this medication to work. And if it doesn't, and honestly, if you've never seen, you can go out and see videos on establishing whether they are a candidate for TPA. I saw this really great in the ER episode where they were talking about this, and it was up in the air for a little while if the patient was a candidate or not. There's several things that test whether it is. So this is exclusive in time spent for E&M services was critical care, 1 hour and 20 minutes. So when you break that down into total minutes, that's 80 minutes because you got 60 plus 20. So you get to code 99291 for the first 75 minutes, and up to each additional 30 minutes, then 99292. Right? So now we've established that they are absolutely critical care. I did link where I got this from, that same stroke site, that journal. Excellent. Take the time to go out and look at it. So now let's get rid of that and let's see the next case, which is going to be case B. So let me go pull that. Oh, you got some good questions I see coming. Thanks. Okay, so now case B, I'm going to open that, bring that over here. What are we going to do first? We are going to establish the verbiage that indicates that our patient is critically ill and needs critical care, and then we're going to establish the time. Now again, these 3 cases are stroke patients, so sometimes the verbiage is going to be the same. So let's get into it. You're called to evaluate a 58-year-old woman, pretty young for a stroke, with aphasia and right hemiplegia. Okay. She was last observed to be neurologically normal at 8 a.m. You arrive at the ER at 11:30. Now, you do not start time at 8 a.m. Why did they put that in? Because it's part of the history. But if you're doing this as a study for a test, you cannot grab the 8 a.m. And if you're perusing this really quickly, you may pick that, right? Because I would. I would write one of my multiple choices as starting the time at 8. It's not the time. You arrive at 11:30. Okay, so this verbiage is going to be about the same. We're going to see their scores of 20. Everything looks pretty good. The scans, okay, nothing's jumping out at me except that you meet with her son and husband. Okay, can she verbalize? No, because she has right hemiplegia on her extremities and she has aphasia. Okay, and you explain that she is past the window for the TPA. That's another thing that you need to understand about TPA. You have to administer it within a specific amount of time from the stroke. So that's why the 8 a.m. is mentioned there. They know that she was fine at 8 a.m. Okay, you're called in at 11:30. And, but if, depending on how much time has gone by since her stroke symptoms started, if you pass that window in the protocol for using TPA, it's out. Okay, so that also, now we're not causing the patient to be in the critical category because they're on TPA and it has to be observed. Now it's because they aren't a candidate for TPA, right? So that means they can't reverse the stroke symptoms. So, so they are saying they could maybe go in and remove the clot, right? Possibly. And then they explain how they're going to do this. This is all kind of fodder for us. Whenever you have somebody, you're going to always see them explain the risk and benefits when they're going to do a procedure, okay? So they go ahead and they proceed with the angiography, and they are going to go in and try to get the clot. You call the interventional neurologist, the interventional neuro doc that's going to go in and try to grab this clot. You call anesthesia to have the patient intubated, right? So they can go in and do this procedure. Yeah, the patient sedated and intubated, and then you accompany the patient to the have the procedure done. The procedure starts at 1 p.m. Okay, you were there at 11:30. You haven't left the patient. You've got this plan of care going, and you actually follow the patient to the procedure at 1. They are able to get, let's see, it looks like they were able to, the interventional radiologist attempts to retrieve the clot. You leave at 1:30 briefly to see another consult in the hospital. What does that tell you? The time stops there, okay? From 1 to 1:30, you're in the suite with the patient, and you're, even though somebody else is doing the work, you're there, okay? It's your patient. But if you leave to go see another patient, time stops. So stop it at 1:30. They get the clot. You return at 2. Time starts up again. So you get to take the time that you've already invested, and it ends at 1:30, but you get to pick it back up at 2 o'clock because you're back with the patient, and that's your only patient. So you go in and you discuss the patient, transfer the patient to 2:30. You write the orders for the ICU. You do the dictation. You also document that you're present during the interventional procedure for the entire time, except for 30 minutes. So you stated how long you were there and monitored the status, and you were part of the contributing factors that decided the treatment. So your critical time is 2 hours and 30 minutes. Now, it would have been 3 hours if you had not stepped away for 30 minutes. So you can't count that, right? So 2 hours and 30 minutes, which is 150 minutes total, right? So we get to code 99291 with 99292 times 3. And if you can't, I went ahead and added this, right? Because we have what? 150 minutes. So let's look at our little chart here. 135 to 164 minutes is 99291 plus 99292 times 3. Now, will they add the time? Yes, they will. They will add the time for you in the documentation, but you still have to verify it and look at it and make sure that they didn't make a mistake, okay? Because if they had stated 3 hours because they thought that they got to count because it was their patient, even though they left, then that doesn't count, all right? You may have to correct them on that. Very good. Excellent. Now, we are on to our next case study. This is the last case study we're going to do like that. I've got some other examples, but these are the 3 stroke case studies. So I'm going to go grab that one and pull that one over. A little different scenario. This time, you're called to the ICU by a nurse, and the patient is a 31-year-old patient you've previously seen in a consult, right? You don't get to count consults, right? We already know that. We said that. However, you were kind of establishing care with this patient because you were able to put a consult, right? You previously saw the patient consult with a right hemisphere stroke that's getting worse, all right? So a 31-year-old patient, that's young to have a stroke. So you arrive at 5 p.m. You do an exam. Now she's already in the ICU, so that kind of establishes that she's critical. However, that's got to be all verbalized that the patient's critical. Why were you called in versus somebody else, right? And what is wrong with the patient that they're in ICU and they need you to come? So the examination shows that it's a he, I guess, that he responds to voice, can open his eyes, but does not follow commands. So you say, you know, George, George, and George opens his eyes, and you say, George, can you blink for me? And he can't blink. Or, you know, you say, can you look to the left? No. Can you move anything? No. Okay. Does not follow commands. Right pupil is larger than the left, which is classic sign of a stroke. Irregular and poorly responsive to light. That's indication of stroke and critical care. He withdraws the right extremities to pain, so he can feel and he can move. But pinch on the left elicits extension of the left arm and triple flexion of the left leg. Ooh. Both plantar responses are extensor. Ooh, this is all good documentation if you don't know how neurology works. You determine that the mental status changes, papillary abnormality, and extensor plantar response on the right are new and suggest impending tentorial herniation. You call the neurosurgeon and order a CT scan right away. You order mannitol, which is something they give them to hopefully thin the blood out. As the nurse prepares the patient for transport to CT, you call the patient's wife and discuss the situation. So that's time because you're still there with the patient. The risk and benefits of doing a depression craniotomy. She consents. You accompany the patient to the CT, right? And then you look at the CT scan right there with the neurologist. So you're talking together, you're still in the care of the patient's under your care. The decision's made to go ahead and do the craniotomy, which literally they just drill a hole in the head. Then the patient's taken emergently to the OR at 6:50. You document the change in the neurological status, that's why you were called in for critical care. Your discussion with the family, you stayed with the patient, and with the neurosurgeon. You stayed with the neurosurgeon. You got 3 things there. You state that you remained at the bedside of the critically ill patient through CT and the decision-making process for a total of 2 hours. Critical care time is 1 hour and 50 minutes, which is 110 minutes. So, looky here. The patient through the CT and the decision-making process for a total of 2 hours. That's 120 minutes. How come we lost 10 minutes, right? Let's go see. 6:50. So the patient is taken emergently to the OR for the procedure at 6:50, and you don't follow the patient into the OR, right? So technically you weren't in there for 2 hours. You were in there for 1 hour and 50 minutes, right? Not 2 hours, because that's all documented. And again, 99291 and 99292 is times 2. And we look down here for 110 minutes, which is right there. There you go. So easy for us, right? When you have that little guide. All right, moving on. Just a coding clinic that I thought was pertinent to iterate to you. Coding clinic, and I pulled this off of the same Find a Code page that I already showed you. They said that, now this is an older one, they said back in 2010, CMS instructed the hospital to report critical care CPT codes in accordance with the CPT guidelines, unless, this is the kicker, instructed otherwise by CMS. Okay, so what the problem was is that CMS was telling them that they had to do it one way and that didn't follow the CPT guidelines. So when they got together and they discussed specifically 99291 way back then, and to tell you, this is the protocol. You do what CPT says unless CMS tells you otherwise, right? And then the AMA had in 2011 a report that ancillary services and their associated charges separately information, and at modifier 59 may be utilized by the hospital to indicate an ancillary procedure. So again, that is a change. Now, let's do some little quick studies. These aren't really case studies, but we want to know, again, about how time works and a little hiccup, right? So we have a 60-year-old patient that's got pneumonia, but keywords, respiratory failure is documented. That's critical, right? And it is, upon examination, it's determined the patient is critically ill. It's documented, I say, critically ill, and they need emergency intervention. So they're going to do endotracheal intubation. And the medical record supports that the doctor spent 78 minutes providing critical care. Okay. However, here's the hiccup. The procedure note states that she spent 32 minutes of that time placing the endotracheal tube. Okay. So, including the pre and post-operative activities associated with placing the tube, 31500. So how do we code that out, right? What are we supposed to do? So if you have 32 minutes for 31500, that's the code. You're going to back out, it says, the critical care time. And there's still 46 minutes of direct critical care work, okay? And it exceeds the 30-minute threshold. So you got to be there more than at least 30 minutes or you don't get to code for critical care. So what do you code? You get to code 99291 for that critical care hour, and you get to code the 31500 for the intubation, the emergency procedure. So some people would think, well, it's encompassed in the 31500 is included in the 99291 because it's critical care. No, they spent 32 minutes doing a procedure which has a code for it. It's not just managing the critical care, right? So you get to use those two codes and they get reimbursed for both the critical care and that time, the 32 minutes spent doing the intubation. Here's a great question. Now, this came up from a neonatal care services question and answer in the CPT assistant. I got this off of Find a Code in those articles that we were looking at. Now, I reiterated putting these codes in because the two codes that we talked about were for not including children, right? They have their own critical care codes, and that's what you're looking at here. So if you have a 5-year-old patient and they come into the hospital as a critically ill, then they're transferred to the PIC unit and managed by the same provider group, but of a different specialty. Now, remember, we talked about that. in the beginning. The question is it appropriate for the PIC doctor to report the initial neonatal care service or subsequent inpatient care? So do we do the 99468 or do we do 99476 and divide it up? How do we do that? So there's the codes. You've got 99468 initial inpatient neonatal critical care per day for evaluation and management of a critical care neonate 28 days of age or younger. And then subsequent inpatient pediatric critical care, same thing, infant or young child 2 through 5 years of age. You think, well, doesn't the age throw it out? Well, let's look. No. Okay, it's not appropriate for the PIC doctor to report initial neonatal care services 99468 or subsequent 99476. The critical care services is provided by the second individual and of a different specialty. So they're not reporting a per day neonatal or pediatric critical care. So in addition, the time-based critical care codes that we use, that we were talking about earlier, are not reportable. They're not going to be able to be used by that same individual or a different individual of the group. So it states the group when the neonatal or pediatric critical care services 99468 through 99476 are reported for the same patient. So you can't code them together. Here's another one about critical care coding, kind of just reiterating. It says, hey, heads up, CMS went through and stated that the hospital must continue to provide a minimum of 30 minutes of critical care services if you want to code 99291. What happened? Well, they were having critical care being done for like 20 minutes. They weren't being reimbursed for it. And so they said, what, can't we get reimbursed? And they said, nope, it's got to be a minimum of 30 minutes. This is where this came from. If you want to look that up, the cms.hhs.gov. And they had also some questions that came out about clarification for hospitals and reporting additional things that happened to the patient while the critical care codes were being used. And again, that just kind of explains what the criteria is. Now, I also wanted to show you that changes are sometimes made. So back in 2009, they kind of deleted a bunch of codes and made new codes for pediatrics. So the new code 99471. If you have an old manual, which you may be able to find, or your encoder, if you put in 99293, I don't even know if it'll come up. It may say that it's not a code. It may come up and say that it's a deleted code and reference 99471. But because I wanted you to know how to research this, I wanted to show you some of the things that you will see when you look at like an encoder like Find a Code. This information was in there. Is it pertinent to us now in the year that we're in, since we're so far out away from 2009? Probably not. However, you may see this type of verbiage or article or information given to you when you're looking at the encoder and you think, isn't that outdated? Well, you need to be aware that there were changes that were made. Okay, and a lot of times they'll explain why the changes were made. You can go back and look, and I did some research and said, why did they do that? So, excuse me. I'm going to drink of water. My throat's dry. So now we have 99471 initial inpatient pediatric critical care per day for the E&M of a critical ill infant or young child 29 days through 24 months of age. Okay, so they clarified it, and we know because we look at codes that are deleted and changed every year that things like this happen. But I just wanted you to be aware of it because I found it there. Now, to wrap up, before we get to the questions that you've got over there, when I was looking at Find a Code, and let me just bring Find a Code back over for that. Like I said, these coding tips, you can look at them. This is where I got that WPS article, and I think now I can, let's see if it'll open for me easily. While that's loading, there were other articles here that were documentation E&M services that are all related to that code. Initial evaluation codes for PT and OT. Here's the question and answer where I got one of those about body systems, Medicare guidelines. That was really interesting. And time-based teaching physicians and residents. You can't do the residents, of course. So here is that article that was required to make sure you had a link if I wanted to use it. I only use this portion, but now you can see how it is much more in depth about evaluation and management documentation and what's required. Okay, so not only critical care, but all of these others. And it would be good for you to go and look at them if you have access to this article. And this just tells you what codes are used. And this is the information that about getting permission to do that. So that is what Find a Code said. Now, I also wanted to show you, not in the articles. Let me get rid of that. That was coding tips, articles, a little different, right? That we went through there's 45 in the CPT assistant, but it goes by year. So at the top will be the most current, and it probably becomes less applicable as you go. And that's where I got the one here. No, it was. I wanted to show you where the codes were deleted. It shows you the deleted codes. But I guess I don't think it was in. It's in there. I guess it's not important that I show it to you, I guess, but just wanted to give you that extra information. One of the features that they have in most encoders too is you can put your own notes in here. So you literally come up with a page and you can type in something. You could even put a link in there to this lecture if you wanted to, if you had access to it. Okay, I'm going to get rid of Find a Code. I want to show you one other thing that I found from them by doing a Google search. This great article, and I did put it in the resources at the bottom.
We lost you, Alicia. Are you there? I think we just lost Alicia. So my apologies, everybody. I think I'm going to exit the webinar now.